Thank you, everyone. Can you hear me? Thanks for giving me the opportunity. I am Ajay Vallakati. I'm one of the heart failure specialists at Ohio State University, and Indra will follow me after the end of the talk. So, starting with the disclosures, neither of us have any disclosures related to the current topic. So the objectives of the talk today are to discuss about pharmacologic management of heart failure, specifically discussing about newer heart failure medications like ivabradine, sacubitril, valsartan, and SGLT2 inhibitors, and also providing some guidance in these heart failure medications for the treatment. Coming to the scope of the problem, once we reach the age of 40, the lifetime risk of developing heart failure is 20%. And with each heart failure hospitalization, the subsequent chances of risk of developing heart failure and hospitalized again in the next 6 months is 50%. And if you look at someone who's hospitalized for heart failure, 5-year survival is close to 50%. And with each heart failure hospitalization, the survival goes down. Coming to the classification, this was the classification that was proposed in the most recent heart failure guidelines. So EF less than 40% is referred to as reduced EF. EF more than 50%, preserved EF. And then EF of 41 to 49% is referred to as mildly reduced or mid-range EF. And we also have an entity called as heart failure with improved ejection fraction. So if you had a patient with EF less than 40%, ejection fraction less than 40%, and it has improved to more than 40%, that would be heart failure with improved ejection fraction. So coming to the entity of mildly reduced, there are no specific studies looking at this patient population. The studies are mostly the data that is extrapolated from preserved EF, and we see that the benefit that you have for medication for reduced EF, you have the same benefit with mildly reduced ejection fraction. So I like to go back, just like Dr. Sharma earlier, and the first trial for the treatment of heart failure was, one of the first trials was in 1987. This was the consensus heart failure trial, and in this particular trial, patients with EF less than 30%, NYHA class 4, were randomized to enalapril and placebo. And at the end of 6 months, there was 40% reduction in mortality. Then in 1991, we had SOLVE trial, which was mild heart failure patients. And these patients were randomized to enalapril or placebo and were followed for 30 months. And at the end of 30 months, there was reduction in all composite of all-cause mortality and heart failure hospitalization. So at this point, ACE inhibitors formed the basis for heart failure treatment. In 1999, we had CIBIS, which was bisoprolol in heart failure. And then you had MERIT heart failure, which was metoprolol succinate, beta blockers, which showed benefits in terms of mortality for the treatment of heart failure. RAILS or RALS was spironolactone in symptomatic heart failure patients, and this showed 30% reduction in mortality. So by 1999, we had ACE inhibitors, beta blockers, aldosterone antagonists, which formed the basis for treatment of heart failure. In 2003, you had sham alternate, that was candesartan in patients who could not take ACE inhibitors, and it also showed benefit in terms of mortality. And then you had COMET, which was carvedilol for heart failure, and then was EPHASIS, which was eplerenone in heart failure, which again showed benefits. And moving on, in 2004, we had AF trial. This was self-identified African-American patients, and they were randomized to receive hydralazine or isodil and placebo, and there was 43% reduction in mortality, 33% reduction in heart failure hospitalization. So all these trials showed benefit in different randomized controlled trials, and if you look at, and if you pull the data, you'll see that there's 19% relative risk reduction in mortality with ACE inhibitors, close to 34% with beta blockers, and 30% with aldosterone antagonists. And this formed the basis of 2013 guidelines. And if you look at the PowerPoint here, you'll see that in patients with reduced ejection fraction, NYHA class 1 to 4, so they need not be symptomatic. You start with ACE inhibitors or an ARB and beta blocker. And if they have good renal function and they have good potassium levels less than 5, you could add spironolactone. And African American patients, if they have room with blood pressure, you add hydralazine and isodal. And in patients who have problems with volume overload, loop diuretics are used to treat the volume overload. So this was 2004. And now I'll talk about the trials that we've had since 2004. One of the first trials after that was the SHIFT, which was ivabradine. And the brand name is Corlinor. And ivabradine is a selective inhibitor of sinoatrial pacemaker. And it slows down the sinus node and without affecting the myocardial contractility or conduction. So its main role is by reducing the heart rate in heart failure patients. And in the SHIFT trial, there were close to 6,500 patients, EF less than 35%, NYHA class 2 to 3, in sinus rhythm with heart rates more than 70 beats per minute, who were randomized to either ivabradine or placebo. And the primary endpoint was a composite of heart failure hospitalizations and cardiovascular death. These patients were followed for 23 months, and the groups were equally distributed, and you see that the majority of the patients were NYHA class 3. And patients were on beta blockers, but only 50% were on dose of beta blockers. And so this was in the context where beta blockers were already the standard of care. Only 50% were on beta blockers. 25% were on target dose of beta blockers. And the main reason that they could not be on beta blockers was dizziness, hypotension, fatigue, and shortness of breath. So at the end of the follow-up period, there was 18% reduction in primary endpoint. And this was largely driven by decrease in heart failure hospitalizations. And if you look at the subgroup analysis, you'll see that the patients who derived maximum benefit were patients who were in sinus rhythm with heart rates more than 77, again, showing the importance of heart rate control in heart failure patients. So ivabradine was approved by FDA in 2015 under the brand name Corlinor for stable heart failure patients with EF less than 35%, with heart rates more than 70 beats per minute, who were on beta blockers, and it was not meant to be a substitute for beta blockers. Contraindications include patients who are in acute decompensated heart failure, patients who had low blood pressure, who already have sick sinus syndrome or sinoatrial block, conduction system issues, who have persistent atrial flutter or HPEF, ivabradine is not indicated. So after that, in 2014, we had our blockbuster trial. And I'll tell you why I call it blockbuster trial. This was the Paradigm HF trial. And the drug that was studied was sacubitril valsartan, also known as Entresto. So most of my patients, when I say Entresto, they know about the drug even before they see me. And that's because it's advertised so much on the TV that patients already want to be on Entresto by the time they see me. Next slide, I'll just take you back to med school. So this is the renin-angiotensin pathway. And if you guys remember, angiotensinogen is produced in the liver. It's converted to angiotensin 1 by renin. Angiotensin 1 is converted to angiotensin 2 by angiotensin-converting enzyme. Angiotensin 2 acts on AT1 receptor. You also have neprilysin inhibitor called sacubitril, and it inhibits the degradation of natriuretic peptides and adrenomedulin. So in the past, researchers looked at combining ACE inhibitors and neprilysin inhibitor, and one such drug was omapatrilat. Both these drugs actually increase bradykinin levels. And with increased bradykinin levels, you have higher rates of angioedema. So when omapatrilat was studied in 2006, there were more deaths in the omapatrilat arm compared to placebo, and the trial had to be stopped early. The researchers then wanted to combine an ARB, angiotensin receptor blocker, with sacubitril, and that is what ARNI is. ARNI, as the name suggests, is angiotensin receptor neprilysin inhibitor. So you have sacubitril, which is neprilysin inhibitor, valsartan, which is an ARB, and a combination of which leads to vasodilation, decreased sympathetic nervous system activity, increased parasympathetic nervous system activity, decreased arrhythmias, decreased fibrosis, more natriuresis, favorable cardiac remodeling. So multitude of benefits. And this was studied in the Paradigm HF trial. These were patients with EF less than 40%, NYHA functional class 2 to 4, over 8,000 patients who were randomized to receive either sacubitril valsartan or enalapril. And the primary endpoint was a composite of heart failure hospitalizations and cardiovascular death. The patients were equally distributed in both the arms. Majority of the patients were NYHA class 2 and 3. And this trial was actually stopped early because there was overwhelming benefit in the sacubitril valsartan arm. There was close to 20% reduction in the primary endpoint. Number to treat was 21. And if you look at other secondary outcomes, you'll see that there was 20% reduction in cardiovascular death, 21% reduction in heart failure hospitalization, and 16% reduction in all-cause mortality. And even there was symptomatic benefit. There was improvement in functional class for the patients on sacubitril valsartan. And this was in comparison to enalapril, which was the standard of care at that time. So in 2016 guidelines, ARNI was recommended as an alternative to an ACE inhibitor or an ARB. And coming to the contraindications, patients who have angioedema with an ACE or an ARB should not be getting this. Pregnant ladies, because similar to the reason that you don't give ACE or an ARB, it's contraindicated. You don't give it with an ACE inhibitor. You don't combine it with an ARB because there's already an ARB. And in the trial, what they did was they waited for 36 hours after the last dose of ACE inhibitor before they put them on Entresto, sacubitril valsartan. And that is what we do in real life too. Coming to the dosing, most people ask me, how do I switch from ACE inhibitor or an ARB to Entresto? So patients who are on a high dose of an ACE, that is more than 10 milligrams of enalapril, or high dose of an ARB, which is more than 160 milligrams of valsartan, you can start with 49, 51 milligrams twice daily. So we get 3 doses. One is 24, 26, 49, 51, and then the third dose is 97, 103 milligrams. Both of them need to be taken, or all the 3 need to be taken twice daily. So patients who are taking a lower dose of an ACE or an ARB, such as less than 10 milligrams of enalapril or less than 160 milligrams of valsartan, or patients whom you are starting who are not an ACE inhibitor or an ARB, or patients who have de novo heart failure, so newly diagnosed heart failure, or elderly patients over the age of 75, you start at a lower dose and then see whether they tolerate the dose. Then after 2 weeks, you can go up and then try to get to a maximum dose of 97, 103. So here I want to talk about the PROVE heart failure trial. This was an open label study. Patients were placed on sacubitril valsartan, and these were heart failure patients who were just diagnosed or who were not taking ACE or an ARB, and who had low NAT BNP levels to begin with. And these patients were followed for 12 months. And after 12 months, the EF, which was around 28% to begin with, increased to close to 38%. And if you look at the LV size, there was decrease in the left ventricular size at the end of diastole, decrease in the size at the end of systole. So overall, favorable remodeling. Next, I want to talk about pioneer heart failure. So we talked about Paradigm HF, which was for outpatient heart failure patients. Pioneer heart failure was for inpatient hospitalized patients. These were 881 patients with EF less than 40, NT-proBNP levels more than 1,600, BNP levels more than 400, and patients who were hemodynamically stable were randomized to get sacubitril valsartan or enalapril. And the primary outcome was reduction in NT-proBNP levels. At the end of 8 weeks, there was significant reduction in sacubitril valsartan. And if you look at the reduction, you see that it reduces as early as the first week, you start seeing the change in the NT-proBNP levels. And in terms of safety outcomes, there was no difference in the rates of renal failure, hyperkalemia, or hypotension between the two arms. There was one patient with angioedema in the sacubitril valsartan arm compared to 6 patients in the enalapril arm. The rates of discontinuation was similar in both the arms. So we talked about outpatient heart failure patients, inpatient hospitalized. What about advanced heart failure patients? And that was the LIFE trial. And these were 300 patients with EF less than 35% who were previously on inotrope or weaned off an inotrope and NYHA functional class 4. And the primary endpoint was the change in NT-proBNP levels at the end of 24 weeks. And this trial showed no benefit with RNA in terms of NT-proBNP levels. And when you looked at the secondary outcomes, there was no difference in the days spent outside the hospital free of heart failure in terms of cardiovascular death or heart failure hospitalization, no difference in terms of hypertension between the arms, and there was more rates of hyperkalemia with sacubitril valsartan compared to valsartan. So coming to the other part of it, in patients with heart failure, what we also deal with is the severe LV dilatation, which can cause mitral regurgitation. So you have functional mitral regurgitation with heart failure. And in this particular study, 118 patients with functional mitral regurgitation were randomized to sacubitril valsartan or valsartan. And the primary endpoint was the change in mitral regurgitation at the end of 12 months. And at the end of 12 months, there was decrease in effective regurgitant orifice area, decrease in the regurgitant volume. And if you look at the number of patients with mitral regurgitation, you'll see that close to 40% of patients on sacubitril valsartan had improvement in mitral regurgitation, and it was stable in the rest of the 60% of the patients. Whereas with valsartan, there was worsening of mitral regurgitation in 10% of the patients. So moving on, sacubitril valsartan can also help with ventricular arrhythmia. So I think this is some of the EP doctors here might be interested. And it was studied in patients with heart failure. There were 120 patients who had remote monitoring capabilities. And these patients were on ACE inhibitor or NARB, beta blocker, and spironolactone. They were followed for 9 months on that regimen, and then shifted to an RNE, and then were followed for another 9 months. And at the end, when they compared both the groups, there was decrease in non-sustained VT, number of PVCs per hour. There was improvement in CRT pacing. There was also decrease in number of ICD shocks that the patient received and number of sustained VT episodes. I want to talk about heart failure with preserved ejection fraction here. So what I mentioned about sacubitril valsartan so far was for heart failure with reduced ejection fraction. It was also studied for patients with EF greater than 45%, and this was the Paragon heart failure. And in this particular trial, over 4,000 patients with EF more than 45%, and NYHA class 2 to 4, NT-proBNP levels more than 300 were randomized to either sacubitril valsartan or valsartan, and the patients were followed for over 2 years. The composite was total heart failure hospitalizations and cardiovascular death. And at the end of the follow-up period, there was no change in total heart failure hospitalizations or cardiovascular death. But if you pay attention here, you'll see that for the total heart failure hospitalizations, the confidence interval actually touches 1. For cardiovascular death, there's no difference in terms of mortality. And if you look at the subgroup analysis in this particular trial, you'll see that for some reason there was more benefit in females compared to males, and there was more benefit in patients with EF less than 57% compared to patients with EF more than 57%. So if there is a take-home slide of my talk, it would be this slide, and this would summarize what we talked about, all the trials. And if the question that would be asked is, can we use sacubitril valsartan for outpatient heart failure patients? The answer is yes. For patients hospitalized, would it be reasonable to start it? Answer is yes. For advanced heart failure, so patients who are on inotrope or who have been weaned off inotrope, could you start? There's not real benefit. Can you start it directly off the bat without starting an ACE inhibitor or an ARB? Yes. Patients with functional mitral regurgitation, again, you can use it in that patient population too. Coming to heart failure with preserved ejection fraction, I just showed you a trial which did not show benefit, but FDA in February of 2001 extended the indication for Entresto to all patients with chronic heart failure, with a caveat that the benefit is most seen in patients with reduced EF. So if you want to try and get it approved for preserved EF, you probably will be able to do it. And Entresto is a great blood pressure medication. And you can actually use it for blood pressure in patients who have a diagnosis of heart failure. Thank you.
Okay, I had a question. So have you seen now that you guys are adding Farxiga to the congestive heart failure patients, the SGLT2?
Yeah.
Because there's big talk on adding those agents because they are indicated now.
Yeah.
And not only in diabetics, but non-diabetics.
So like now, you probably might have heard about the 4 pillars of heart failure treatment that's been used all around. So 4 pillars, and Indra would talk about the 4th pillar, that SGLT2 inhibitor is the 4th pillar. The first pillar would be ACE inhibitor, ARB or ARNI, and ARNI would be my first choice. Second would be the beta blocker. Third would be an aldosterone antagonist like spironolactone or eplerenone. And Indra will talk about the 4th pillar.
What about patients who are allergic to ACE and ARB?
So it depends on the allergy. So I've had in situations where the patients had angioedema, I've avoided ARNI altogether. I've had patients with hyperkalemia secondary to an ACE and an ARB, and we've used potassium binding agents like petiromere to treat the hyperkalemia and then actually place them on an ARNI with that.
If they're not able to tolerate ARBs, then?
They would. So this has more blood pressure lowering effect than an ARB. So if they can't tolerate ARB, highly unlikely that they'll tolerate ARNI.
What about cough as a side effect?
So if cough is secondary to ACE inhibitor, I've used with an ARB or ARNI, they've tolerated the medications pretty well. So that was the CHARM alternate trial, and it's worked for me.
What about use of diuretics with these agents? Have you seen lowering of their dose? Or?
So that's what empirically what we do is, I might have mentioned it, but it also has the natriuretic effect. So the sacubitril part of it increases the natriuretic peptide. So you have more diuresis with this drug. And we actually try to go down on the diuretic. So I try to halve the dose of diuretic when I add Entresto. And I also tell the patient that if they start getting lightheaded or dizzy, then we might just need to stop the diuretic because this medication is doing the job. And that would be one of the reasons that if the patients are dehydrated or hypovolemic, and if you try to add this drug, the patients can get lightheaded, dizzy, and I've had patients actually don't be strictly against starting this medication because it was started when they were on the dehydrated side, and they can have profound diaphoresis, and they might not be agreeable to taking this medication later on, even though it's it provides so much benefit in heart failure.